Welcome to Dr. Garry. On this channel, we break down blood pressure and heart health topics using medical research, public health data, and evidence-based information, so you can better understand your numbers. Brand new research, published just 3 weeks ago, is about to make you question everything you thought you knew about blood pressure. For decades, doctors have repeated the same advice. The ideal reading is 120/80. That's the target. That's what everybody should be chasing. Lower is better. Push those numbers down as far as possible. But this new study out of the Journal of the American Medical Association reveals something alarming. For seniors over 65, pursuing 120/80 may actually be harmful, increasing the risk of falls, strokes, and even death. After more than 20 years in cardiac medicine, I want to give you the real picture about blood pressure targets for older adults. I'm not going to give you the actual number just yet, because if I do, some of you will jot it down and click away. You need to understand why this number works differently in seniors. You need to see what happens when blood pressure drops too low in an older body. You need the full story before the number makes any sense. But before any of that, you need to hear what happens when a senior strives to hit 120/80. You need to understand that for older adults, lower is not always safer. Sometimes lower is fatal. Comment below your current blood pressure numbers and your age. This data is critical. Eleanor's story. Let me tell you about Eleanor, because her experience will permanently change how you think about blood pressure. Eleanor was 78 when I first saw her. She'd been living with a high blood pressure diagnosis for 10 years, since she was 68. Her doctor put her on medication right away, started with one pill. Eleanor's reading at diagnosis had been 152/88. After 2 months on medication, it came down to 138/82. Her doctor was encouraged. "We're getting there," he said, "but we need to reach 120/80. That's the goal." He increased the dose. 2 months later, Eleanor's pressure was 128/76. Better, but still short of the target. A second medication was added. "We really need you at that ideal number," he told her. 120/80. That's where your risk of heart attack and stroke is lowest. That's where you'll be safest. Eleanor trusted her doctor completely. She'd been his patient for 20 years. She took both medications faithfully and monitored her pressure at home. After 2 months, her reading was 122/78. Practically at goal, her doctor was delighted. "Perfect. This is exactly where we want you." At first, Eleanor felt fine. A little tired, maybe. But she was 78, and tiredness felt normal. Then something odd started happening. Whenever she stood up from a chair, the room would spin. Just for a few seconds. She'd have to grab onto something until it passed. She mentioned it to her doctor. "That's probably just age-related," he said. "Your blood vessels aren't as flexible as they used to be. It takes a moment for pressure to adjust when you stand. Stand up slowly. Take your time." Eleanor did exactly that, but the dizziness never went away. Every time she stood, every time she got out of bed, every time she rose from the sofa, she began to dread standing, began moving with fearful caution. Her daughter noticed. "Mom, you're moving like you're scared. What's going on?" Eleanor described the dizziness. Her daughter urged her to call the doctor again. The nurse phoned back. "The doctor says as long as your blood pressure looks good, the dizziness is probably just age. Make sure you're drinking enough water." Then, 3 months after her pressure reached 122/78, Eleanor woke in the night needing the bathroom. She sat up in bed, swung her legs over the side, and stood. The room spun violently. Her knees buckled. She reached for the nightstand and missed. She fell hard, her right hip striking the corner of the nightstand on the way down. Her husband found her on the floor, crying, unable to move her right leg. He called 911. The paramedics checked her pressure, lying down, 118/74, sitting, 94/62, standing, 82/54, severe orthostatic hypotension. Her medications had lowered her pressure so aggressively that her body could no longer maintain adequate circulation when she changed position. Her brain wasn't receiving enough blood when she stood upright. That was the dizziness. That was the cause of the fall. X-rays at the hospital revealed a completely fractured hip. She needed surgery, a full hip replacement, but Eleanor was 78. The orthopedic surgeon walked her through every risk. Infection, blood clots, pneumonia, anesthesia complications. There was no alternative. Without the operation, she would never walk again. The surgery went well, but recovery was brutal. A week in hospital, 3 weeks in a rehabilitation facility, learning to walk again. Twice daily physiotherapy, exhausting, painful. Before the fall, she had been fully independent, shopping, attending church, visiting friends. Now she needed help with everything. She felt like she'd aged 2 decades in a single night. Eleanor eventually returned home, but she wasn't the same. Fear had settled into her. Fear of walking without a frame, fear of moving too quickly, fear of being alone. Her world had contracted. Months passed. Then, 6 months after the fall, Eleanor developed pneumonia. She'd been so sedentary, too afraid to move, that fluid had quietly accumulated in her lungs. Pneumonia in a 79-year-old with limited mobility is extremely dangerous. She was hospitalized, given IV antibiotics and oxygen. But her lungs couldn't clear the infection. Her body was too weakened, too deconditioned from 6 months of near immobility. Eleanor died 3 days after admission. Her daughter was devastated and angry. She was fine before they pushed her pressure that low, she told me later. She was active, independent, happy. Then they hit 120/80 and she started falling. That fall started a chain that ended with her death, all because her blood pressure was too low. But her doctor said 120/80 was perfect. How can perfect kill someone? That's the question. And the answer is this: 120/80 is not perfect for everyone. For people over 65 and especially over 70, targeting that number can be genuinely dangerous. Falls, fractures, decline, death. Comment dizzy below if you experience dizziness when you stand. This is a serious warning sign that your blood pressure may be too low for your age. Eleanor's death was preventable. If her doctor had understood that 120/80 was too low for a 78-year-old woman and had targeted a higher number, she would likely still be alive today. Still independent, still active. But he was working from outdated guidelines that don't account for age or the distinct physiology of older adults. Why seniors are physiologically different. So what is the right blood pressure for seniors? I will tell you. But first, you need to understand why older adults operate by different rules. Why what works for a 40-year-old doesn't apply to a 75-year-old. And why 120/80 that's perfectly fine for a middle-aged person can be harmful for an elderly one. Reason 1. Arterial stiffness. As you age, your arteries become less pliable. They stiffen. This is called arteriosclerosis. Stiff arteries don't absorb the pressure wave from each heartbeat as efficiently. The result? You actually need slightly higher pressure to push blood adequately to your vital organs, especially your brain. In a younger person with flexible vessels, 120/80 is more than enough to maintain good brain blood flow even when standing. In an older person with stiff arteries, that same reading may leave the brain underperfused the moment they get up, causing dizziness and increasing fall risk. Reason 2. Slower baroreceptor response. Baroreceptors are pressure sensors inside your blood vessels. In young people, they react almost instantly when you stand, signaling the heart to beat faster and the vessels to constrict, maintaining stable pressure. In older adults, these sensors respond more slowly. So when blood pressure dips, as an older person stands, the body's correction mechanism is delayed. If their baseline is already near 120/80, that delay can mean a dangerous pressure drop before the body compensates. This is orthostatic hypotension, and it causes falls. Reason 3. Changes in medication metabolism. Older adults process medications differently. Kidney and liver function both decline with age, meaning drugs stay active in the body longer and hit harder. A dose appropriate for a 50-year-old can be excessively strong for an 80-year-old, pushing blood pressure dangerously low. Reason 4. A different risk equation. In younger adults, the primary danger of high blood pressure is long-term damage, heart disease, stroke, kidney disease accumulating over decades. In older adults, the immediate risk from low blood pressure can outweigh the long-term risk from moderately elevated pressure. A fall caused by low blood pressure can kill an 80-year-old within months. Blood pressure at 140/85, by contrast, may cause no serious problems for years, if ever. The calculation is fundamentally different. For a 50-year-old, chasing 120/80 makes sense. They have decades ahead and long-term damage prevention matters. For an 80-year-old, fall prevention may matter more than hitting a textbook target. Now you're ready to hear what the evidence says, and it contradicts what most doctors were trained to believe. The traditional guideline, everyone aims for 120/80, was built on studies done primarily in middle-aged adults, people in their 40s, 50s, early 60s. Those studies confirmed that lower pressure reduces heart attack and stroke risk in that age group. True enough for them, but very few studies looked specifically at people over 75 or 80, and the ones that did found something unexpected. The major SPRINT trial, published in 2015, examined intensive blood pressure lowering, comparing a target below 120 systolic against a target below 140. The intensive group showed fewer cardiovascular events. This fueled widespread pressure to push numbers as low as possible. But here's what got lost. The sprint trial excluded many typical older adults, people with diabetes, prior strokes, or frailty. Its results don't necessarily apply to the average 80-year-old. Then came the research I mentioned at the top of this video, published just 3 weeks ago in JAMA. This study tracked 15,000 adults over 75, including those with diabetes, prior strokes, and frailty. They examined outcomes across different blood pressure ranges. Here's what they found. Among adults over 75, those with systolic blood pressure between 130 and 140 had the lowest mortality, lower than those below 120 and lower than those above 150. The group below 120 had significantly increased rates of falls, fainting episodes, acute kidney injury, and death. The group above 150 had elevated stroke and heart attack risk. The sweet spot, the pressure associated with the longest survival and best quality of life, was 130 to 140 systolic. The researchers were surprised, but when they dug deeper, it made sense. Slightly higher pressure in older adults provides better perfusion to vital organs, especially the brain. It prevents orthostatic hypotension. It cuts fall risk, and these real-world benefits outweighed the theoretical cardiovascular risk from the marginally elevated reading. Why your target number is personal. That said, I'm still not handing you a single target number because the right number is not identical for everyone. It depends on your age, your other medical conditions, your level of frailty, and how your body responds to medication. Let me show you what I mean. Harold, age 72. Harold's pressure was 146 over 88. His doctor wanted it at 120 over 80 and started medication. After 2 months, Harold reached 124 over 78, but he felt awful. Exhausted, dizzy, unable to concentrate. His quality of life had dropped sharply. I reviewed his case. He was otherwise in good health, active, no diabetes, no heart disease, strong kidney function. For someone like Harold, 146 over 88 wasn't truly dangerous, and the medication side effects were significant. We dialed back the medication, let his pressure settle at 136 over 82. Harold felt dramatically better. Energy returned, dizziness gone, mind sharp, and 136 over 82 was perfectly safe for a healthy 72-year-old. Margaret, also 72, same age as Harold, completely different picture. Margaret had diabetes, a prior heart attack, and reduced kidney function. For her, 146 over 88 was genuinely risky. We needed to lower it, but 120 over 80 would have been too aggressive given her conditions. We targeted 130 over 80, achieved it through careful medication adjustment. She tolerated it well, no dizziness, no fatigue, and her risk of another cardiac event was meaningfully reduced. Same age, different targets, because they were different people with different risks. Comment below your age and whether you have diabetes, heart disease, or kidney disease like this. 72, diabetes, heart disease, or 68, none, or 80, kidney disease. Ruth, age 83. Ruth was 83, frail, managing diabetes, heart failure, and chronic kidney disease. Her pressure was 168 over 92. Her doctor wanted to bring it down aggressively. I disagreed. Ruth was already weak and unsteady, already at elevated fall risk. Pushing her pressure lower could tip her over the edge. We kept Ruth's pressure at around 160 over 90, higher than conventional targets, but the safest option for her specific situation. She remained stable. No falls, no hospitalizations. She stayed independent. 5 years later, Ruth was still alive and still at home. Had we pushed for 120 over 80, I believe she would have fallen, declined rapidly, and died far sooner. William, age 70. William was 70, healthy, and active. Golfing twice a week, no significant medical issues. His pressure was 142 over 84. His doctor wanted 120 over 80, but William felt great at 142 over 84. No symptoms, plenty of energy, excellent quality of life. My assessment, for someone like William, 142 over 84 was fine. The risk from that reading was minimal. The potential benefit of pushing it to 120 over 80 was small. The risk of side effects from more aggressive treatment was not. We left it alone. He continued golfing, traveling, and living well. No complications, no problems. Most of the discussion about blood pressure targets centers on the top number, systolic, the pressure during each heartbeat. The bottom number, diastolic, pressure during the rest between beats, matters too, but differently in older adults. As you age, systolic pressure tends to climb because of arterial stiffening. Diastolic often stays flat or even drops. This creates what's called a widened pulse pressure, a larger gap between the two numbers. A 70-year-old reading 150/75 has a pulse pressure of 75. This can be completely normal, reflecting the natural stiffness of aging arteries. What you want to avoid in older adults is very low diastolic pressure. When diastolic drops below 60, blood flow to the heart during the relaxation phase between beats is compromised. So while a systolic of 140 may be acceptable in an older person, diastolic should ideally stay above 65 to 70. Eleanor's resting pressure was 122/78. Systolic slightly lower than ideal for her age, but diastolic was reasonable. The crisis came when she stood and her pressure crashed to 82/54. A diastolic of 54 is dangerously low. Her heart was not receiving adequate blood flow during relaxation, contributing directly to her dizziness and the fall. What happens in the brain? When pressure is too low, blood has to travel upward against gravity to reach the brain. In younger people with flexible vessels and quick baroreceptors, that's no challenge. In older people with stiffer vessels and slower sensors, adequate brain blood flow requires adequate pressure. When systolic pressure in an older adult drops below roughly 110, brain perfusion decreases, not enough to cause immediate damage, but enough to produce symptoms: dizziness, lightheadedness, confusion, fatigue, difficulty concentrating. These are often written off as just aging. They may actually reflect insufficient blood flow to the brain. Brain imaging studies have shown that older adults with very low blood pressure have reduced flow to specific brain regions. Over time, this may contribute to cognitive decline, memory difficulties, reduced ability to handle complex tasks. Some researchers believe overly aggressive pressure lowering in seniors could be contributing to rising dementia rates. This remains controversial, but the possibility is deeply concerning. There is also a kidney consideration. Your kidneys require adequate pressure to filter blood effectively. Too little pressure leads to declining kidney function, especially in older adults whose renal capacity is already reduced. Studies have found that aggressively lowered blood pressure in older patients sometimes triggers acute kidney injury. So the balance point becomes low enough to reduce stroke risk from elevated pressure, but high enough to maintain brain and kidney perfusion, and high enough to prevent orthostatic hypotension and falls. That balance sits higher in older adults than in younger ones. Now for specific numbers. These are evidence-based guidelines, not absolute rules. Your personal target should be determined with your doctor based on your full medical picture. Ages 65, 75, healthy and active with no major medical conditions. Target: systolic 130, 140, diastolic 70, 85. This range provides adequate organ perfusion while still delivering meaningful cardiovascular protection. Ages 75 to 85, relatively healthy. Target: systolic 135, 145, diastolic 70, 85. Slightly higher than the younger group, accounting for increased arterial stiffness and slower baroreceptor responses. Over 85 or frail at any age. Target: systolic 140 to 150, diastolic 70, 85. Here, the priority shifts clearly to fall prevention and quality of life. The risk from a fall is more immediate and potentially more lethal than the risk from a slightly elevated reading. Older adults with diabetes, prior stroke, or heart disease, targets may need to be somewhat lower, perhaps systolic 130, 135, but still not as aggressive as a 120. Close monitoring for side effects and orthostatic changes is essential. Older adults with chronic kidney disease, this is nuanced. Moderate lowering can protect the kidneys. Too much lowering can starve them of the pressure they need to function. Targets are highly individualized, often in the systolic 130-140 range. Comment which category applies to you. For example, 65 to 75 healthy, over 85 frail, or 75-85 with diabetes. The most important test, checking for orthostatic hypotension. Beyond hitting a specific number, the most critical thing is to identify and avoid orthostatic hypotension. If your blood pressure drops significantly when you stand, that is the real danger, regardless of what your sitting or lying reading looks like. Here is how to test yourself at home. You will need a blood pressure monitor. Lie down for 5 minutes, take your blood pressure, record the reading, stand up, immediately take your blood pressure again while standing. If your systolic drops by more than 20 points or your diastolic drops by more than 10 points, you have orthostatic hypotension. That is a warning sign requiring medical attention. For example, 130/80 lying down, dropping to 105/68 on standing. That's a 25-point systolic drop. Dangerous, even though 130/80 appears to be a reasonable reading. Eleanor's pressure was 118/74 lying down, crashing to 82/54 standing, a 36-point systolic drop. That was the dizziness. That was the fall. If this had been caught earlier, her medications could have been adjusted and the tragedy prevented. Thomas, age 74. Thomas's pressure was 128/76. His doctor was pleased, but Thomas kept reporting dizziness when standing. His doctor dismissed it. Your pressure is fine. It must be something else. I asked Thomas to do the orthostatic test at home. Lying, 128/76. Standing, 98/58. A 30-point systolic drop. Significant orthostatic hypotension, despite an apparently good resting number. We reduced one of his medications. His lying pressure edged up to 136/80, but his standing pressure improved to 118/72. Just an 18-point drop. The dizziness resolved. Thomas felt well again. His doctor was uneasy about 136/80, calling it above guideline recommendations. But Thomas wasn't dizzy, wasn't at risk of falling, and 136/80 is not dangerous for a healthy 74-year-old. Quality of life and functional safety, that is what matters. Your complete protocol for finding your ideal blood pressure. Here is what I recommend you do in partnership with your doctor. Step 1. Monitor at home consistently. Take readings morning and evening. Keep a log for 2 weeks. Home readings are more reliable than office readings, which can be artificially elevated or suppressed. Step 2. Test for orthostatic hypotension. Do the lying to standing test described above. Even if your overall pressure looks acceptable, a significant postural drop means your medications need adjustment. Step 3. Pay attention to how you feel. Dizziness, unusual fatigue, brain fog, difficulty concentrating, these may signal your pressure is too low. On the other hand, if you feel well and energetic, your current reading may be working for you even if it doesn't match a textbook target. Step 4. Factor in your full medical picture. Diabetes, heart disease, kidney disease, prior stroke. All of these influence where your ideal target sits. This is not a one-size-fits-all number. Step 5. Have a real conversation with your doctor. Bring your home readings. Bring your orthostatic test results. Bring this information. Ask them to individualize your target based on your age, your conditions, and your quality of life. Not just a guideline written for a 50-year-old.